to the Dermatology podcast from the Dermatology Education Foundation. The Dermatology podcast is made possible with support from Johnson & Johnson. In dermatology clinics across the country, thousands of procedures and excisions every day require local anesthetic. But what happens when there is a lidocaine shortage? That was one of many questions posed by attendees at this year's DEF Essential Resource Meeting, or DERM. DEF Advisory Council members and DERM faculty members Sandri Johnson and Jayme Heim took time to answer questions from attendees. Here's Sandri Johnson.
Always excited to be here. Being part of the faculty at the DEF is one of the highlights of my life. My name is Sandri Johnson. Like Paul mentioned, I am a nurse practitioner in North Carolina, but in dermatology for 21 years. And I love to share tidbits of information and help in education.
Hello, I'm Jayme Heim, and I'm also very glad to be here, and I really feel that it's so important to have APP education. I work at West Michigan Dermatology in Michigan, and I've been an NP for almost 20 years.
All right, so you guys, as faculty members, are available to answer questions from the attendees, and we got several of them, especially in the app. So one of them was someone asking if anyone's seeing a lidocaine shortage, and if so, are there alternatives? What can you do? So tell us, are you seeing that or not?
We sure are, Jayme.
Yes,
you want to talk about your experience first?
In our office, we have a really busy office. So we have 3 sites in our office. So we have Mohs surgery as well as multiple biopsies that are carried out throughout the day. And after COVID, we saw this lidocaine shortage. And so we have continued, because we can't get enough lidocaine in our office. We actually have we make it up ourselves. It's a 1% lidocaine with epi and a 1 to 10 solution of 8.4% sodium bicarb. Along with that, it has to be documented in EMA. And so that is in EMA, it's documented, and it goes down to a 0.5% lidocaine.
We're experiencing similar. Our office is not as busy. We don't have Mohs surgeon. So most of the procedures that we have are simpler procedures that don't require that much anesthesia. So we, for the more complex excisions, we might use alternatives to lidocaine like Marcaine or bupivacaine, which you have to keep in mind. It might have a slower onset of action, but it will have a longer duration of activity. So that is beneficial. We occasionally will also use saline as an alternative, but we try to keep our volumes down. We also do a dilution with bicarb and epinephrine.
In a similar vein, we had a question about just making shots more comfortable in general. We obviously know some patients are scared, just don't like any pain. What are some of the things that people can try to make the experience more comfortable for patients?
I'm presuming we're talking about shots that people will administer at home and not the shots that we give in the office.
I think if there's anything you're doing in the office as well, though, too.
Well, the first thing is, at least for us, is we don't rush through any of that. We want to have a comfortable environment. We are always trying to be very goal-oriented, to keep in mind what is it that we're trying to achieve. If it's clear skin with a psoriasis or a atopic dermatitis injection, very goal-oriented. One of the things that I've done since my children were young is I came up with this concept of a mommy's magic Band-Aid. So a prescription of the cream that has lidocaine and prilocaine, put a little bit of that on the pad of a Band-Aid and put it where you're going to be injecting, and then about an hour later, open the Band-Aid, cleanse the area, give the injection there, so you have a reduction in pain for that. We also use cool compresses, vibration as well, any other mode of distraction. How about you, Jayme?
I think that really, it's not only children, but it's adults too.
Very much so.
And so it's really nice that those adults too that want to come in for that injection in the office, I find that having somebody else talk to them while you do the injection, or lots of times they will look at their phone, and that's a great distractor. EMLA always works very well, which you were talking about, and that works very well. So anything that can be used as a distraction mode. Also, I will use the Buzzy. On children as well as on adults. And then also sometimes it's like even just applying that pressure. And so it kind of takes away that pain for that area, and in going ahead and doing your injection. That really helps. That really helps a lot. For children, I find that especially when you're doing injection site reaction, in the parents and that, to go ahead and show them how to hold. So it's really important to show them how to hold. My little bit older children, I always have something there to give them as an incentive. I have 3 little things that they can pick from, and then they can go ahead and pick from it. So then they're more likely to, because they really want that little gift afterwards.
Their surprise.
Yes, exactly. And so that really helps them to use the EMLA too. And then too, an iPad helps too for those younger children in that. But if the parent, and especially if it's a younger child, just to hold them and put the legs down between one of their legs and that, well, I give the injection or that, because lots of times they don't feel comfortable doing that. That works really well, and I'll have my MA who's in the office work with me, and they'll do the distraction. Bubbles actually work very good too for children. Children love to watch bubbles because it distracts them enough.
I think we all do.
Exactly.
And adult loves a bubble too.
So there are really a lot you can do to distract adults as well as children.
It's a great inexpensive tip too. I mean, bubbles are cheap.
Yes, they are cheap.
You're listening to the Dermalorian podcast from the Dermatology Education Foundation. We'll get more insights from Jayme Heim and Sandri Johnson in a moment. But first, it's time for this episode's Dermalorian clinical clip. Multiple factors can influence the selection of a biologic treatment for psoriasis with or without joint involvement. But the order of FDA approval shouldn't be one of them. That's according to dermatologist Dr. Jennifer Soung.
Do I have to use biologics? Do I have to start with a TNF and then go to Stelara and then to the next? Who says you have to use drugs in the order in which they were approved? So, we have the reason why more drugs are invented is because they're safer and better efficacy. So, in terms of Stelara, I was using for a very long time because this was one of the biologics with more convenient dosing in our adolescent patients with plaque psoriasis. So that's kind of where it had settled in the recent years. But just about a week or two ago, Tremfya or guselkumab is now FDA approved for as young as 6 years old, which is huge. Even though Stelara or ustekinumab I've used for so long, the safety is so great. Parents still read the package insert, so you kind of have to guide them through it and talk about real world evidence. And it's so nice to be able to offer one of the IL-23 drugs because the package insert along with the IL-17s is just so clean. It's really simplified, made that safety discussion so much easier. In fact, all of our safety information fits on one slide these days when I'm talking to you about IL-17s and IL-23s. Guselkumab is now approved as young as 6 years old. They also have recent data that shows not only does it help for the signs and symptoms of psoriatic arthritis, but it also prevents radiographic progression. So they actually did further studies to really show that a 23 can be powerful to prevent that radiographic progression.
Sticking with the theme of safety, let's get back to nurse practitioners Sandri Johnson and Jayme Heim for updates on the use of dietary supplements in dermatology.
We also got a lot of questions about supplements. Specifically, the first part was hair supplements. So do you guys recommend them? What are your thoughts on those for your patients?
This is definitely a big one. We deal with a lot of hair loss in our clinic, and this is a very emotional diagnosis. For some of us as providers and clinicians, it might be personal to us as well. So doing a lot of research on what's out there and what works. And there's so many campaigns of by manufacturers that, might not have data to back up their claims. But yes, we definitely recommend vitamins for hair loss specifically. I personally like Nutrafol. A shout out to them. They're here. I find them to be very effective. I've seen it in not only personally, but in a lot of the patients, with a downside of cost on that one. So we have to be very mindful about what the treatment of all these diagnoses actually will cost. So Nutrafol is the one for me.
Yeah, I agree. And I think that patients, lots of times, they're looking for supplementation because they want something more natural. And there are several different, pathophysiologic reasons why there is hair loss. And so, it's part of our job to really find out really why this patient is exhibiting the hair loss it is. Is it patterned hair loss? Is it because they've just gone through, a lot of patients we saw that went through COVID and they ended up having intelligent effluvian. I mean, things like this, so finding out and then educating towards that. But overall, good supplements sometimes are very expensive. And as you know, we do not have an FDA-approved supplement. And so therefore, trying to seek the best guidance is sometimes difficult. So I would say also, too, for those patients who maybe just cannot afford something like Nutrafol, and I've done this, and what we have is we have a formulary in our local pharmacy or grocery store, and it has a prenatal vitamin. Overall, good prenatal vitamin. It has all of those minerals and everything in it. So, and that's what I've done too. If people just want to take something and they're not ready to, do other things at that point.
If it helps grow a baby, it might help you grow some hair.
That's exactly right.
Great point.
Exactly.
So then people were asking just more broadly about supplement recommendations. Is there anything that you think can be beneficial? And is there anything you either don't want patients to take or you need to know if they're taking?
That's a very broad question because there is so much. I mean, I think when it comes to overall health, there's a lot of vitamins that we recommend just for these support of our immune system. For example, vitamin D is your master vitamin to support your immune system. Vitamin C, a very powerful antioxidant, but so we're talking about hair and collagen. We need that vitamin C to even produce collagen or assimilate collagen. Zinc is a big one for us in dermatology for wound healing, etc. We deal with a lot of inflammatory disorders as well. So omega-3s are big in our office. And then probiotics, gut health. We have learned over the last few years how the core of our immune system is within our microbiome in our gut. So gut health is big. And another antioxidant would be maybe CoQ10, coenzyme Q10 for the antioxidant. The last one that is just big now is magnesium, right? So magnesium is getting all the hype. Yes. And it's not hype, it's true, because magnesium is another master vitamin that will help your muscles. It helps your bones, cardiovascular health, mood, sleep, energy. So that's becoming a large recommendation in my office is magnesium.
I really don't exclude anything. If patients would like to try these supplements, I don't have a problem with it. As long as it's not detrimental to their health, and as long as they're not taking over what the FDA suggested amounts are for those. Because too, if you take too much of a supplement too, there is a side effect to that. There is a toxicity for some of them.
Correct. Yeah.
And so that's why you really have to be mindful of that. But if it's not going to be harmful to them, absolutely, why not?
Yeah, your fat-soluble vitamins, your A, D, E, K are the ones that you have to be mindful of what we recommend. Of course, we're mostly dealing with vitamin D from the ones that I recommend, but too much is, more is not always better.
And I think it's important you started with vitamin D when you first started to answer. And I understand that this whole story is kind of resurfacing again, that people want to get out in the sun because they want their vitamin C, but they can take a supplement and they'll be fine.
Yeah,
that's right. And a lot of times in primary care, primary care, when they see patients with psoriasis, they think, oh, you know what, you're probably vitamin D deficient. Let's just draw your vitamin D level. And it comes back normal. And so there's not a lot of times that they have to supplement with vitamin D, because really we do get enough vitamin D, most of us do. And so that is one thing that needs to be educated on a little bit better.
This is the Dermalorian podcast, made possible with support from Johnson & Johnson. Before we conclude this episode, we turn to dermatologist Dr. David Cohen for this episode's Dermalorian Derm Decoder. Dr. Cohen addresses chronic hand eczema and a new treatment option, delgocitinib.
During the annual DEF meeting, Joe made quite an announcement that topical delgocitinib cream became available for the treatment of chronic hand eczema. Chronic hand eczema is a difficult and vexing inflammatory condition of the hands caused by a multiplicity of causes, right? It could be allergic contact dermatitis, irritant contact dermatitis, physical natures, endogenous causes, and atopic dermatitis, right? It is not one cause, it is a multiplicity of causes. And we really had limited treatments available. We were really borrowing treatments from eczema and sometimes systemic immunomodulatory or immunosuppressive therapy to get control. Hands are critical to our activities of routine daily living. We use them from the moment we wake up to perform routine activities to performing almost every aspect of our work, right? So when your hands, although 1% of the total body surface area of your fingertips, you can't do just about anything you need to when they're inflamed. You can't zip your pants up or button your shirt or certainly perform a punch biopsy or liaise with clients on a regular basis while your hands are inflamed. So finally, we have a pan-JAK inhibitor that had remarkable safety and remarkable efficacy at alleviating the signs and symptoms of hand eczema. I think we're all excited to have that opportunity to use it.
Thank you for joining us. The Dermalorian podcast is produced for the DEF by Physician Resources. If you've missed episodes, catch up now wherever you get your podcasts, and be sure to tell your colleagues. Stay tuned for more clinical insights and practical tips from the DEF.